Hello, good afternoon. Today is Monday, and around 1 o'clock on March 14. This is again Professor Nick. I'm a physician assistant from Brooklyn, New York, with 20 years experience in any subspecialty, starting from medicine to surgery. I would like to introduce you my GI lectures for MPPA board exam. Let's start with stomach. Let's go to the first slide. First slide discuss GERD. The definition of GERD is this is inappropriate relaxation of the lower esophageal sphincter, which result of acid contents from the stomach coming to the esophagus. Usually these symptoms are worsening by nicotine, alcohol, caffeine, chocolate, peppermint, late night meals, and obesity. When the question asks what is the most likely diagnosis, you'll see a patient with epigastric burning pain, which radiate to the chest. The patient also complains of sore throat, bad taste of the mouth, which is metallic, hoarseness, or cough. There is a clinical tip here, which is that states that there is no unique physical finding of GERD. It is just a symptomatic complex, and also states that you don't need to have all the extra symptoms presenting in order to answer GERD as a most likely diagnosis. Let's go to the next slide. Next slide discusses diagnostic tests for GERD. As we said before, GERD is a symptomatic complex. It's a base of the patient's history. Some patients, the diagnosis is not clear. You need a 24 hours pH monitoring to confirm the etiology. Also, you can use endoscopy when you have one of the following symptoms. Number one, signs of obstruction, such as dysphagia or odynophagia. Number two, when you have weight loss. Number three, if you have anemia or chemopositive stools. Number four, when you have 5 to 10 years of symptoms, you have to exclude Barrett esophagitis. And with endoscopy, if the endoscopy shows nothing, when there is only pirosis or heartburn, this is a clinical tip. Also, endoscopy may show redness, erosions, ulcerations, strictures, or Barrett esophagitis. The treatment of GERD is the patient needs to follow the following protocol. Weight loss if they're obese. This is number one. Number two, avoid alcohol, nicotine, caffeine, chocolate, or peppermint. And they need to avoid eating at night before sleep. Say for example 3 hours before bedtime, and they need to keep the head elevated 6 to 8 inches. Let's go to the next slide. We have various possibilities for GERD, from mild or intermittent symptoms to persistent symptoms or erosive esophagitis. The mild or intermittent symptoms may be treated with the liquid antacids or H2 blockers. The persistent symptoms or erosive esophagitis, they can be treated with PPI. There is really no difference in efficacy between different PPIs. And if the patient does not respond to medical treatment, this is like 5% of the patients, they need to go for surgical or anatomical correction by tightening of the lower esophageal sphincter. And there is 3 ways of doing this. Number 1, Nissen fundoplication. This means wrapping of the stomach around the lower esophageal sphincter. Number 2, endocinch, which is using the scope, we can place a suture around the LEC to tighten it. Number 3, we can use heat or radiation to the lower esophageal sphincter or LES, which will cause scarring, will form a scar. Go to the next slide. This is slide number 5, which discusses Barrett esophagus. Long-standing GERD can lead to histological changes of the lower esophagus. Usually leads to columnar metaplasia. At least you need 5 years of reflux to develop this type of complication. There is no unique physical finding or laboratory test for Barrett esophagus. How we diagnose that is we need biopsy, and this is the one and only way to be certain of presence of Barrett esophagitis. And this is indispensable because the biopsy drives the therapy. The columnar metaplasia has the greatest risk for developing esophageal cancer. And on the right side of the slide, we have here a nice table which talks about findings and the management of each finding. If we have only metaplasia or Barrett alone, we only treat this with PPI and rescope every 2 to 3 years. If we have a low-grade dysplasia, we treat this with PPI, but we rescope the patient every 6 to 12 months. And if we have high-grade dysplasia, we certainly do more for the patient. We do ablation with the endoscopy, photodynamic therapy, radiofrequency ablation, and the last one is endoscopic mucosal resection. And here there is a clinical tip that each year about 0.5% of the people with Barrett esophagitis progress into esophageal cancer. Let's go to the next slide. This slide, this is slide number 6, talks about gastritis. Gastritis, this is basically the definition for gastritis, is inflammation of the gastric lining, which is called gastropathy. Can be caused by several reasons. Number one, alcohol. Number two, NSAIDs. Number three, Helicobacter pylori. Number four, portal hypertension. Number five, stress such as birth, trauma, sepsis, multi-organ failure, example, uremia, and also can be caused by number six, atrophic gastritis, which is frequently associated with vitamin B12 deficiency. If the question asks what is the most likely diagnosis, gastritis usually presents with GI bleed without pain. Also, the severe erosive gastritis can be presented with epigastric pain. NSAIDs or alcohol are also in the history are also clues. And there is a clinical tip here. You cannot answer the most likely diagnosis question only based on the history and the physical exam alone. Gastritis also can be presented with any degree of bleeding from mild coffee ground emesis to large volume vomiting of red blood or black stools melena. Here there is a clinical tip also in the right lower corner that there is no unique physical finding for gastritis. Let's go to the next slide. This slide discusses the diagnosis and treatment of. Nice meeting you. This slide discuss the diagnosis and treatment of the GI bleed, and here we need to talk about that only the upper endoscopy can be definitively diagnose so-called erosive gastritis. Although anemia can occur, there is no specific blood tests. We need to know that radiological studies such as upper GI bleed series will be not specific enough. So-called capsule endoscopy is not appropriate for upper GI bleed. The testing for H. pylori should be performed because this organism can be treated if it is associated with gastritis. On the right side of the slide, we see a table which have the correlation between manifestation of the GI bleed and the volume of bleeding. If there is a coffee ground emesis, the volume of bleed is 5 to 10 cc. If it is hem or Goyak positive stool, it's between 5 and 10 cc. And if it is melena or black stools, the blood loss is 50 to 100 cc. Let's go to the next slide. Slide number 8 discuss the treatment with PPI and treatment of testing and treatment of H. pylori. We need to note here that H2 blockers, liquid antacids, and sucralfate are not effective as a PPIs. Sucralfate or aluminum hydroxide complex, it's a inert substance which coats the stomach. If sucralfate is present in the choice, it's always the wrong answer. PPIs are indicated for so-called stress ulcer prophylaxis In case of number 1, mechanical ventilation, number 2, burns, number 3, head trauma, and number 4, coagulopathy. On the table on the right side of the slide, we see every test which we do, the pros and cons. Let's go with the first test, which is endoscopic biopsy. This test is the most accurate of all tests, but require invasive procedures such as endoscopy. For serology, for H. pylori, it is inexpensive, easy exclude infection if negative, and no complication or procedures required. But the problem for the serology is that lack specificity. A positive test does not easily tell the difference between current and previous infection. Also, we can do is urea C13 or C14 breath testing, which is positive only in acute infection, which is non-invasive. And the other fact is that requires expensive equipment in the office. And the last one is H. pylori stool antigen. This test is positive only in active infection, which is non-invasive. It is non-invasive test. And the other thing is requires stool sample. Let's go to slide number 9. Slide number 9, we need to discuss is peptic ulcer disease or PUD. By definition, PUD refer both to duodenal ulcer and gastric ulcer disease. They cannot be distinguished without endoscopy. The etiology is most commonly related to H. pylori. NSAIDs are the second most common cause because of the effect is inhibited. The effect is the inhibition of production of protective mucous barrier of the stomach. And it is a fact that NSAIDs inhibit the prostaglandin, and the prostaglandin produce mucus. The most common cause for peptic ulcer disease are burns, head trauma, Crohn's disease, gastric cancer, and gastrinoma or Zollinger-Ellison syndrome. NSAIDs produce more bleeding than pain. This is a clinical fact. And another clinical tip is that alcohol and tobacco does not cause ulcer, but they delay the healing of ulcers. Very important. Let's go to the next slide. Slide number 10. And let's finish for this slide number 10. Endoscopy is the only method which can detect gastric cancer. And we need to note here that a very important clinical fact, cancer is presented in 4% of those with GU, but none of those patients with DU. It means that only gastric ulcers can cause gastric cancer in 4%, not duodenal ulcer. Let's go to the next slide. Go to the next slide. Slide number 13. Here we need to discuss so-called non-ulcer dyspepsia. Non-ulcer or functional dyspepsia is when we have epigastric pain for which we cannot identify the etiology. The disorder is only diagnosed on endoscopy. The pain of non-ulcer dyspepsia or NUD can be identical as a gastritis, PUD, gastric cancer, or reflux disease. If the patient is under 45 years old, treat them empirically with anti-secretory therapy such as PPI and scope only if the symptoms does not resolve. Endoscopy is definitively not indicated initially for those which are younger than 45. For those which are over 55, endoscopy is definitively indicated to exclude cancer. Between 45 and 55, the answer is unclear. We have here a clinical tip. We need to scope patients with dyspepsia only if the patients are over 55, if we have alarming symptoms like dysphagia, weight loss, anemia. And this is the clinical tip which we need to remember. The cause for NUD is unknown. NUD is the most common cause for epigastric pain. And the best initial therapy is PPI. NUD is not definitively associated with H. pylori. So the cause for NUD is unknown. NUD is the most common cause for epigastric pain. The best initial therapy is PPI. NUD is definitively not associated with H. pylori. However, so if there is no defined benefit from treating a NUD with antibiotics and eradicating Helicobacter, yeah.
Quick question, sorry.
Yeah, no.
STD testing is lavender and yellow.
We're now on slide 14. This slide discusses different type of therapies for non-ulcer dyspepsia. On the left side there is a clinical fact that if the symptoms persist and H. pylori is present, we have to treat the patient for H. pylori. So different for non-ulcer dyspepsia, initial therapy depends from the age. If patient is younger than 45, initial therapy needs to include PPI and no need for upper endoscopy. If the age is from 45 to 55, the therapy needs to include PPI, but the need for upper endoscopy is unclear. For age of over 55, initial therapy includes PPI and the patient needs to have upper endoscopy definitively. Let's go to the next slide. Next slide is slide number 15, which discusses so-called gastrinoma or Zollinger-Ellison syndrome. This slide discusses that 1% of those which have ulcer disease can develop gastrinoma, less than 1%. And here we need to look for a patient which has the ulcers are larger than 1 or 2 centimeter. Number one. Number two, they are recurrent after Helicobacter eradication. They're distal of the duodenum and they are multiple. And there is a clinical fact here that gastrinoma is openly associated with diarrhea because of the acid inactivates the lipase, and that's why the patient presents with diarrhea. Let's go to next slide. Slide number 16 discuss laboratory findings in imaging, laboratory testing and imaging of Zollinger-Ellison syndrome. The most accurate diagnostic test, this is endoscopy. We'll find high gastrin levels when the patient is off PPI or H2 blockers with high gastric acidity. The high gastric levels are despite high gastric acid output, and the presence of high gastric levels despite that patient was injected with secretin. Anybody which has 3 or more of these findings can confirm that patient has gastrinoma. The single most accurate test is functional test, which is looking for response of gastrinoma. Also, there is a clinical fact here that hypercalcemia is a clue for multiple endocrine neoplasia, which can cause hyperparathyroidism. The imaging studies here for this type of clinical situation is that once the diagnosis of gastrinoma is confirmed, we need to exclude metastatic disease. So that's why CT and MRI of the abdomen have a poor sensitivity, but needs to be done. Negative CT or an MRI does not exclude metastasis. Somatostatin receptor scintigraphy, or so-called nuclear octreotide scan, which is combination of endoscopic ultrasound to exclude metastatic disease. There is here clinical fact that gastrinoma is associated with massive increase of the numbers of the somatostatin receptors in the abdomen. Let's go to the next slide. Slide number 17, which discuss so-called diabetic gastroparesis. We have here clinical vignette, which talks about 64 years old patient with diabetes for 20 years, comes to your office and complains of several months of abdominal fullness, intermittent nausea, constipation, and cessation of bloating. On physical exam, patient has a splash over the stomach on auscultation when moving the patient. Which is the most common next step of management? A. Abdominal CT. B. Colonoscopy. C. Erythromycin. D. Upper endoscopy. And E. Nuclear gastric emptying study. The right answer for this vignette is erythromycin. When we have diagnosis of diabetic gastroparesis, there is no need for diagnostic testing unless there is a failure of the therapy. Erythromycin and metoclopramide increase the gastrointestinal motility. And the most accurate test for diabetic gastroparesis, this is a nuclear gastric emptying study, although it is rarely needed. For long-standing diabetes, cause dysmotility, gastric dysmotility. Also, distension of the stomach and intestines is normally the most important stimulant for motility. Gastroparesis is autonomic neuropathy leading to dysmotility. Dysmotility is from inability to sense the stretching of the GI tract. If the question asks what is the most likely diagnosis, we need to look for a patient with diabetes, which includes chronic abdominal discomfort, bloating, and constipation. There is also so we need to look for a patient which has a chronic abdominal discomfort, bloating, and constipation. Also, there is anorexia, neuropathy, vomiting, and early satiety. Let's go to the next slide. In this slide, discuss GI bleed. Etiology is most common is ulcer disease, and we have to remember this clinical fact. But also can be caused by gastritis, esophagitis, duodenitis, cancer, and varices. So the most common cause for lower GI bleed, this is diverticulosis, and can be also caused by angiodysplasia or IV malformation. Number 1, number 2, polyps or cancer. Number 3, inflammatory bowel disease. Number 4, hemorrhoids. Number 5, upper GI bleed with rapid transit from high volume. Here there is a clinical tip that assessing also we need to know that upper GI bleed can have a rapid transit to a high volume. There is a clinical fact here which states that assessing of the blood pressure is the most important initial management for GI bleeding. So we need to assess the blood pressure. And there is a different type of etiology of GI bleed. Most common cause is ulcer disease for For upper GI bleed and for lower is diverticulosis. The other causes for upper GI bleed, that's esophagitis, gastritis, cancer, duodenal ulcer disease, or lower GI bleed. The most common cause is diverticulosis, and next to it is other causes are polyps, inflammatory bowel disease, cancer, upper GI bleed itself, and hemorrhoids. Let's go to the next slide. Next slide discusses the physical findings of GI bleed. There is a table on the right side of the slide which discuss the severity of the blood loss based on the hemodynamics. If the patient has orthostasis, means 15 to 20% of the blood loss. 15 to 20% of the blood loss. If the pulse is over 100 per minute, there is 30% of the blood loss. And if the systolic blood pressure is less than 100, it's 30%. We need to remember that more than 10-point rise of the pulse, it happens when we have the patient to lie down and sitting or standing position. And also if the systolic blood pressure drops up 20 points or more, then when sits up. Next slide, slide number 20, discuss varicose bleeding. The only form of GI bleeding which physical findings can help determine the etiology. This is varicose bleeding. When we have the presence of liver disease, we may establish the diagnosis. Varicose bleeding is so here, if there is signs of liver disease, as we said, we need to establish the diagnosis. Varicose bleeding is suspected when the case describes vomiting blood plus minus black stools, also suspected varicose bleeding is when we have vomiting with blood plus minus black stool, spider angiomata and capus medusae. Another is when we have and also we need to have see hepatomegaly, pulmonary erythema, and hysterexis. This is a clinical fact that initial management of GI bleed is not based on the etiology, it's based on severity. Slide 21. We have diagnostic testing for acute bleed. When the bleeding is severe, it is far more important to replace the fluids and check the hematocrit, platelet counts, and coagulation profile, such as prothrombin time, or PT, or RNA, than to do an endoscopy. NG tube. 10% of those with red blood from rectum have a high volume upper GI bleed with rapid transit time. NG tube can rapidly identify the upper GI bleed and who needs upper endoscopy for banding before colonoscopy. The sensitivity of NG tube is about 70%. Also, you can see bowel in the aspirate, and you know that NG tube aspirate really is fully sensitive. If the stool is black in a person with cirrhosis, then there is no hematemesis. An NG tube shows red blood may tell you to use octreotide for varices and arrange urgent endoscopy for possible banding of the varices. The upper endoscopy also, if the stool is black in a person with cirrhosis, but there is no hematemesis, NG tube shows red blood and may tell us to use octreotide for varices and to arrange urgent endoscopy with possible banding of the varices. Clinical fact: if upper endoscopy will be done anyway, there is a limit role of NG tube. Clinical fact: NG tube placement is there is a very limited benefit. There is no therapy to be delivered through the NG tube, but it can guide where to start with the endoscopy. Let's talk about slide 22. Here there is a clinical fact that 80% of the GI bleeding will stop spontaneously if fluid resuscitation it is on time and sufficient enough or adequate. Most patients die due to inadequate fluid replacement. On the right side of the slide, there is a very nice table about different type of diagnostic testing. Test number 1, this is nuclear bleed scan. Indication for this is that endoscopy is done in case of massive acute hemorrhage and lacking accuracy. Also, there is another test which is called angiography. This is when a specific vessel or site of bleeding needs to be identified prior to surgery or embolization of the vessel. It is used only in massive non-responsive bleeding. Another test, this is capsule endoscopy. Usually it's done when you have a small bowel bleed, and you do upper and lower endoscopy when does not show the etiology. Another test, this is a CT or MRI of the abdomen. Usually is not useful for GI bleed. Also, we can do is EKG and lactic level, which can show ischemia in severe bleeding. Let's go to the next slide. Here we discuss how to treat GI bleed. We need to replace the fluids with high volume fluid replacement, 1 or 2 liters an hour of saline or ringer lactate for those which have acute severe bleed. Number 2, pack red blood cell if the hematocrit is below 30 in those who are older or suffer from coronary artery disease. If the patient is young, transfusion may be not needed until hematocrit is below 20 or 25. Number 3, fresh frozen plasma or FFP. When PT or INR is elevated and active bleeding is occurring. Number 4 is platelets. When we give patient platelets when the platelet count is less than 50,000 and there is a bleeding. Number 5, we give the patient octreotide when we have a varicose bleeding. Number 6, we do endoscopy to determine the diagnosis and administer some treatment. Band varices, cauterize ulcers, inject epinephrine into the bleeding gastric vessels. Number 7, IV PPI for upper GI bleed. And number 8, surgery to remove the site of bleeding if fluids, blood, platelets, and plasma does not control the bleeding. There is a clinical tip here which states that platelets are transfused when the platelet count is less than 50,000, when there is active bleeding, and you would not transfuse platelets to prevent spontaneous bleeding unless the count were much lower, like between 10 and 20,000. Let's go to the next slide, which is the last slide. And here we will discuss esophageal and gastric varices. Here the first point is that what do you do in case of fluids, blood, platelets, and plasma? You do octreotide or somatostatin, which decrease the portal pressure. Number 3, you do banding after endoscopy obliterates the esophageal varices. You do transjugular intrahepatic portosystemic shunting or TIPS to decrease the portal pressure in those which are not controlled by octreotide or banding. Number 5, you do propranolol or nadolol when we have to prevent sequential episodes of bleeding. Beta blockers such as propranolol will not do anything for the current episode of bleeding. Number 6, antibiotics is to prevent SBP with ascites. Here there is a clinical tip that sclerotherapy is never the right answer if banding is technically possible. And the clinical here tip, as we said, the sclerotherapy is never the right answer if banding is technically possible. And this is the end of the lecture, slide number 24. Thank you so much for your attention. If you have any questions, please feel free to email me at nickm like Mary, D like dog, number 1 at gmail.com. Once again, this is Professor Nick Nicolo from Brooklyn, New York, PA Nick. Thank you so much. Or the Triple Nick, they call me the Triple Nick. Ciao. See you in the next lecture.